hopefully I can, care of the underserved in Alabama. I have nothing to disclose. I'm not representing any of the medications or being paid to represent any of the medications. In this country, we do have an epidemic problem with diabetes, and this problem is getting worse by the day. And I have been involved in diabetes a long time, my entire life, basically. But currently, we have 37 million Americans with diabetes, and this number is not getting any better. We have approximately 28.7 million people in this country that have diagnosed diabetes, but we have a large number of undiagnosed individuals, approximately 7.3 million. But what's concerning to me, and hopefully I'm sure that concerning to a lot of you, is that we have 96 million pre-diabetes Americans that are not aware that they actually are headed toward the door of having full-blown diabetes. They have what we call pre-diabetes, 96 million. That's an ICD-10 code or a medical code that is R73. That's a billing code that we can actually see patients for pre-diabetes, and to keep them from getting diabetes, that we could start them on medications to prevent them having full-blown diabetes. And there are recommended guidelines for this. And if they're overweight or have overweight or obese, we can start on treatment regimens. And I can talk about that later. But a large portion of those who have pre-diabetes are overweight and or obese. The direct cost or indirect costs, both of those combined, direct and indirect costs in this country for diabetes alone is $400 and almost $13 billion. I'm not sure exactly right off the top of my head of that exact cost for Alabama, but in the country, $413 billion for the cost of diabetes. The 8th leading cause of death in this country is what diabetes is doing. One thing that we do know is that we can prevent diabetes type 2, not type 1, but we can prevent diabetes type 2 by healthier lifestyles and weight loss. We can turn diabetes type 2 around. It has been proven, so it is critical that we can prevent that. It is a significant problem in this country, and it is an urgent, epidemic, and costly problem. According to ADA, nearly 1/2 of the United States adults have diabetes and or pre-diabetes. That's what I was just mentioning to you. And about every 21 seconds in this country, someone is diagnosed with diabetes. That's personal. That is something we all need to think about. Is it going to be us? Is it going to be our brother, sister, mother, grandchild? Who is that going to be? If the current growth pattern continues, as many as 1 in every 3 American adults could have diabetes by 2050. And this is according to what the CDC is warning us as Americans. The high cost of diabetes extends to other chronic conditions. And we know that patients with diabetes have severe chronic conditions, and this cost continues to escalate. Personally and professionally, I care about diabetes. I have had diabetes type 1 for 50 plus years. I have been on insulin for 50 years. And not only is it personal to me, I professionally am caring for patients in Alabama in 2 diabetes clinics. And both of those clinics, I'm caring for the underserved. I get a little shaky because I get emotional about it, because I care, and my heart is broken because just like yesterday, I had a patient come in with a 14.8 A1C and a blood glucose of 450. And they told me that the reason their blood sugar was high is because they could not afford their medication. And because they needed some type of PA to get their meds. So I had to start new medications yesterday that was affordable. And I apologize for saying that, but it is real fact in this state that our patients cannot get their medications. But I have my medications because I have insurance that's covering those meds. And I thank God for the medications that I have through the insurance. So it is personal, but I can tell you this, diabetes is not what I wish for any man in this state to have. So we must prevent this, and so we must decrease obesity. Diabetes is challenging, diabetes is hard, and diabetes is escalating out of control. And the state of Alabama is well known across this country for a great football team. Why can't we be great for reducing obesity and managing our patients with diabetes and preventing this chronic disease from spreading and getting worse? I wish that a lot of you could come and work with me in my 2 clinics, whether it's in Birmingham or whether it's in St. Clair County, and look at the patients that I care for that are in renal failure, that are blind, or that do not have their lower extremities because diabetes has eaten them alive. In this great state, approximately 550,000 Alabamians, or 14% of the state of Alabamians, have diagnosed diabetes. 119,000 Alabamians have diabetes but do not even know it. But it's increasing their risk for other chronic conditions. There are approximately 1.3 million people in Alabama, or 35% of Alabamians in this state right now, who have prediabetes related to their weight. 1.3 million people in this state have prediabetes. Prediabetes means that we need to prevent diabetes. That means that they are high risk. And when I see patients that are overweight in my clinic that come in because they have an abnormal blood sugar, or that they're morbidly obese, or that their BMI is 29 or 30, which is obesity at 30, and their primary care provider sees that they're overweight and they send them to my diabetes clinic and they ask me to treat them because they're prediabetes, which is an ICD-10 code, like I said, of R73. They send them to me for diabetes, which they have not been diagnosed as diabetes, but prediabetes. And they say, Annette, do something. And I go in and I tell my patient, I look them sitting down face to face, and I tell them, you are headed toward the door right there to walk through full-blown diabetes because your pancreas is about to stop working fully because your insulin level that I just checked is high, which means your pancreas is overworking. How many of you know what your pancreas level is? Annually, an estimated 34,668 adults in Alabama, annually, almost 35,000 people in Alabama are diagnosed with diabetes. 35,000 every year in Alabama are diagnosed with diabetes. Why? Because of obesity. We in Alabama must do something to decrease the obesity in this state. I tell you what, I've been in Alabama my entire life, and I am old. I am real old. I am 60 years old. I was diagnosed with diabetes at age 10, and I have lived my life all in this state, and I want diabetes to go away. It will never go away, but obesity can get better. And one thing in Alabama that I know we all love is our Southern food, and we love our cornbread, and cornbread kills my blood sugar. And so I can only have a 1-inch square. Now you Southerners try to eat a 1-inch square cornbread. And it's not fun and it's not easy, but we try. Obesity is linked to 30 to 50% of new cases of diabetes in this country yearly. Obesity is the major and has been the major driver of diabetes for the last 2 decades. Obesity-related diabetes greatest impact among non-Hispanic white females. Reducing the prevalence of obesity may prevent up to half of the new cases of type 2 diabetes in the United States, according to the Journal of the American Heart Association. I'm going to go ahead and click all of these so you can see the complications of obesity and diabetes. I want you to just look at this. This basically are the complications of obesity and diabetes plus some. This affects the entire body. As a provider, I take care of all of these because they're related to diabetes and obesity. Depression, stress, cancer, gallbladder disease, cardiovascular disease, high blood pressure, liver disease, arthritis, sleep apnea, snoring and sleep apnea, stress incontinence, immobility, chronic kidney disease, and you keep going. Complications are serious with diabetes and obesity. Eyes, blindness, kidney failure, peripheral vascular disease, periodontal, their teeth, the gum disease, also neuropathy, lower extremity amputations. I had a young patient yesterday that came in that he was 28 years old, had a below-the-knee amputation, and he was blind in his left eye, and his A1C was 17.1. I asked him, how long has it been since he's seen a provider? He said he has no insurance, and he did not have any money. I said, how long has it been since you've seen a provider? And he said, but I have no insurance. I asked again. He said, it's been 4 years. Weight stigma. Individuals who are overweight have different treatments among different people and different entities of businesses. You have to look, they may have to pay for 2 seats on an airplane. They may have to pay for a more expensive amount of money for their clothing. And we have to look at what we can do to improve the stigma for patients who are overweight. We also need to boost their self-esteem. We also just need to help provide health care for those who need it and provide the affordable health care and medications for those who want to lose weight. This statement came out in 2014. That is the year that obesity was determined that it was a chronic disease with an ICD-10 code of, it was E66.8 for obesity and 66.9 for morbidity, for morbid obesity. Weight management within primary care practices is the foundation of prevention and management of chronic diseases. Weight management within primary care practices is the foundation of prevention and management of chronic diseases. I tell my patients all the time, if we could lose weight, if you could lose weight, we could decrease your heart rate, we could decrease your blood pressure, we could decrease your blood glucose, we could decrease your cholesterol, your triglycerides, we could decrease your blood glucose, we could increase your kidney function, we could increase your self-esteem, we could make you feel better if we could lose some weight. We could decrease the cost and put some money back in your pocket by decreasing the number of medications that you're paying for every month and your insurance is paying for. I can help you get off some of those blood pressure medicines, help you get off of the cholesterol medications, and decrease some of your blood sugar medications if we can lose some weight. I would like to say at this point that my sister-in-law in October received a clean bill of health. She's morbidly obese, and she went to her doctor and received a clean bill of health, and they sent her home. 4 weeks ago, she went to work at UAB. She got to her desk, and she sat down. She started having shortness of breath, and she got real hot, and she said she wasn't feeling well. She called her boss who was in the building. She said, I need some help. I need someone to come help me. She's worked at UAB for several years. Her boss ran to her. they called a code. They got a gurney, they went and got her, 911 came, they took her to the emergency room at UAB and took her straight to surgery. She had 100% heart blockage. She also had an A1C of 10.8. How do you have a normal, healthy, 100% good as gold health check in October and then have 100% heart blockage 4 weeks ago, which was in November? Are we treating our patients with obesity like we should be treating them? As a provider, annual guidelines is what guides my practice. I'm not going to go through all of these, but I would like for you to know about them. American Diabetes Association Standard of Care Guidelines guides my practice. Also, obesity guidelines guides my practice. And also, I look at hypertension guidelines from the American Heart and the kidney disease guidelines from the National Kidney Foundation. Those are what guides my practice. I look at these every year. They come out annually. So I look at them to see what has changed and what's recommended for my practice. I do not go from what I was taught in school 20 years ago because protocols change, medications change, and we have to stay up to date on what's going on. These three physicians here are world-renowned and Alabama-known physicians and researchers. You can look up any of these three people. This is Dr. Donna Ryan, Dr. Tim Garvey, who is on our task force, and Dr. Jamie Ard, A-R-D. Jamie is J-A-M-Y. These three individuals, I've worked with all three of them. I worked with Dr. Jamie Ard for 8 years in the Eat Right Clinic at UAB. He's a cardiologist, but he's also on the Obesity Society board. Dr. Tim Garvey is on the American Association of Clinical Endocrinology board, and Donna Ryan is also on the Obesity Society board. They are top-notch as far as knowing what is best and what is recommended for diabetes and or obesity. Dr. Tim Garvey also states that right now we can turn obesity around and diabetes risk by 60%. If we can decrease the weight of many Americans and Alabamians, we can decrease the risk of diabetes by 60% by using the medication semaglutide. And this is very important to know, by 60%. In the state of Alabama, 1.3 million Alabamians have prediabetes. If we can reduce that by 60%, how many Alabamians? Is that 775,000 Alabamians could prevent having diabetes? 775,000 Alabamians could prevent having diabetes by the use of semaglutide. Healthcare goals, I want you to see that I look at healthcare goals and try to keep my patients or get my patients to these goals. And I look at the hemoglobin A1C, which should be less than 6.5 for ACE, which is American Association of Clinical Endocrinology, or ADA says less than 7. How many of you know what your A1C is? Also, your blood pressure should be less than 130/80. And the total cholesterol, the total should be less than 200. I look at that. Triglycerides should be less than 100. Also, your insulin level. Your insulin level is the level that we look at to determine how hard or how much is your pancreas working. Is it working excessively? Some of the insulin levels that I check in my overweight patients and patients who are morbidly overweight, insulin levels I have seen as high as 68 and 70. Okay, this shows that their pancreas is overworking. Something that overworks day in and day out and day in and day out will eventually do what? It will eventually wear out and it will stop. Okay, once it stops, that pancreas is dead, it will not restart. But if we can decrease the weight, we can reduce that insulin level and get that pancreas back up and running. If we can lose weight, if we can lose 10 to 15% of their body weight, we can get that pancreas back up and going. Weight loss wins, wins, and wins. Body mass index less than 25. African Americans, I tell my patients less than 27 because their bone structure is larger. Waist circumference for women less than 35. For men less than 40. Do you know what your waist circumference is? Is it within the parameters here? And C-reactive protein. This is a blood test that we check to look to see what this is. It's an inflammatory marker. It's an indicator of a risk factor for heart disease because patients who are overweight have a higher C-reactive protein. And patients who are overweight, we see this a lot. And I let them know as your weight is higher, you're going to be at a higher risk for a cardiac event. And I can look at them and tell them, we're going to get your weight down to prevent this. I know I'm running out of time, but I am going to just show you a few things that if we can just look at this, go back to this, if you can get these levels down, weight loss will get these levels down, every one of these. The blood glucose will come down, the blood pressure will come down, the A1C will decrease, the cholesterol will decrease, triglycerides will go down, the kidney function, the GFR, that's the filtration rate. If your weight comes down, the kidney function will increase. We want that to be higher. And their self-esteem will get better. The goal of diabetes type 2, primary weight-centric approach, obesity is recognized as a disease associated with morbidity and mortality. And the biggest focus is decrease weight to reduce the diabetes in this country and this state. And again, this is what Dr. Garvey said in his research. We can reduce the risk of diabetes by 60% by weight loss. Dieting is good. Healthier lifestyle is good. That is important. But patients who are normally eating every day as much as they want to, it is hard to break a habit. It is hard. We have to help them with an appetite suppressant and also changing the hormones ghrelin and leptin. You look those two up, ghrelin and leptin in the body, G-R-E-L-I-N, and leptin, L-E-P-T-I-N. Look those two up in the body and what they are, and knowing that one goes up and one goes down and how that changes the appetite and increasing the appetite or decreasing the appetite. And exercise is important, portion control of the food, how much food, which foods are healthy. In the South, vegetables are not all vegetables. We have starchy vegetables and we have healthy vegetables. Patients in my clinic think they're eating vegetables and they're not eating anything but a plate of carbohydrates. And that's what needs to be done. We need patients to understand how to lose weight. Weight loss benefits. I've mentioned this already. The benefits of losing weight will help everything in the body, everything from head to toe, in lowering their blood glucose and all the parameters that I've already mentioned. These are slides that I've mentioned to you from those guidelines previously mentioned. And I want to mention that even if a person's A1C is normal, according to the American Diabetes Association, and a person who is overweight, American Diabetes Section 10 states that if a person is overweight and say their A1C is 6.8, which is abnormal, okay, because it should be less than 6, it should be in the 5 range. But if they have risk factors for cardiovascular disease, it shows that we should be treating them, and it shows an SGLT2 inhibitor or a GLP-1 receptor agonist, such as semaglutide, which is what researchers have shown would reduce the risk of diabetes by 60%. So even if they don't have full-blown diagnosed diabetes, but they have pre-diabetes and they're obese, we could start, according to the guidelines that are produced every year, we could start semaglutide and be supported by these guidelines right there. And that's what guides our practice as providers. And again, weight management is an impactful component of glucose lowering management in type 2. Also, again, pharmacologic therapy for adults with type 2 and obesity, the semaglutides, and also the GLP-1 in all these guidelines. And again, this is from the American Association of Clinical Endocrinology. Over here on the far left, under lifestyle, and then you go with the first column, starts with metformin, the GLP-1, which is the semaglutides, and the SGLT2, such as Farxiga, and meds such as that. That's where we start, and every one of them start with those. And the same thing is another type of algorithm from this year, from ADA 2023, and at the very top, I know you can't see that with your micro eyes. I know you'd have to have them to be able to see that, but at the very top, it says the same thing. I'm just showing you what these protocols show, and this says the same thing. If a patient has risk factors of cardiovascular disease and diabetes or no diabetes, but have cardiovascular risk factors and obesity or overweight, to start these medications, the semaglutide, the SGLT2s, or the GLP-1s, or both. Again, weight management with primary care practices is the foundation of prevention and management of chronic diseases. Overweight and obese patients are leading to chronic diseases, not just diabetes, but that's the first one. And then along comes the cardiovascular diseases and kidney disease and all the others that I showed you on the slide with all the complications. In Alabama, if 60% of 1.3 million or 34.6% of Alabamians with prediabetes and weight concerns could reduce their weight or their obesity with semaglutide, which is 780,000 Alabamians with having diabetes. To prevent that, 780,000 people in Alabama could be prevented from having diabetes, which could be your family member, saving millions, if not billions of dollars in this state from our pockets, improving their health outcomes and their quality of life. Why not pay for the recommended guidelines from these organizations that recommend GLP-1s and or SGLT2s, such as semaglutide? Because I promise you, living with diabetes is not fun, and I would not wish this on any one of my patients that I care for every day. Why would we not do this and prevent 780,000 people in this state from having diabetes? Thank you. Some of them were, but some of them were with diabetes, and some of them were without, but with having cardiovascular disease.
Right, but intermixed, not just necessarily somebody with, excuse the expression,
Right.
And those guys, that remains undefined.
Right.
Somebody walks in.
The American Association of Clinical Endocrinology, some of those came from there, and they do have, their guidelines are for obesity. Some of those were intertwined with those, and they were with the same. And that's why I put that slide, the link for the American Association of Clinical Endocrinology, so you could go there as well. But that's a great question because they also are recommending the same type that to reduce their weight.
And can I ask a question in your practice?
Yes.
You were talking about somebody with prediabetes, let's say, just an A1C at 5.9.
Yes.
BMI of 35.
Yes.
And they walk in. What's your first line? How do you begin to treat that patient in your practice?
Okay. And I do have some of those patients, and I start them on metformin. And also I check their insurance, and I check to see if they're on Medicare or Medicaid. And then I also have nutrition therapy come in because we have a team there, and they come in to see those patients. And then I also will talk to them about Trulicity and or Ozempic, and then we go from there because
Any discussion of exercise?
we do. We have a physical trainer, and we talk about that. And we also look at their mobility, what they're able to do, and because we have to look at their cardiovascular function and what they're able to do as far as their mobility, and making sure that they do not have any limitations. And we also have access to Lakeshore if they can just tolerate swim therapy, because some of them cannot get out and walk.
How about if they come in, for example, you said cardiovascular risk factor, hypertension?
Okay?
Does that change things at all?
I treat them for but they have primary care providers, but also for patients with diabetes, they all should be on an ACE inhibitor, which is a medication like lisinopril, okay? For that is a renal protective medication and also good for their blood pressure. And we look at that as well. But that is also a cardiovascular issue. So we look at that as well. And with their weight loss, it could help that. But with patients with diabetes, okay, we keep them on that ACE inhibitor.
That's not necessarily a pre-diabetic. You treat the cardiovascular the same. But in somebody with diabetes, obviously, control hypertension is even more important.
Oh, yes. 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 And I look at that, and also I look at their cardiovascular. I look at their cholesterol and their triglycerides. And so most 90% of my patients, when I look at their top three diagnoses, it's diabetes, hypertension, and hyperlipidemia.
I was very taken by, the example of the patient walked in with very high blood sugar, no insurance, can't afford it. How often is that a problem? That it's not really medications, but lack of access and due to lack of insurance?
At one of my clinics, that's all I see. And at my clinic in Birmingham, some of them have insurance. They have insurance, and their copay for some of their medication is still out of their pocketbook range.
Basic things, maybe not metformin, which is generic, but for any sort of other medication.
So are they able to get those? Some of them can. Some of them are they do not have any insurance, so they get the funding from, like with the county. And so they get that funding through the state and the county. And then some of them do have insurance, some have Medicaid, and some have Medicare.
Overarching.
It is. It is. Right. And then and my St. Clair County clinic is all no Medicaid, no Medicare, and no insurance. And it's all funded through donations and patient assistance, like Novo and Lilly. They provide for those patients. thank you. Thank you. Thank you.
From the obesity perspective, so from an obesity standpoint, when you're talking about for guidelines on food advocacy, then comprehensive care for obesity is important, right? So we talk a lot about medication, we talk a lot about, but the four pillars from obesity guidelines are nutrition, behavioral intervention, exercise, and also pharmacology, as well as muscle surgery. So pharmacology, from that standpoint, the problem is that studies overall have absolutely shown that lifestyle intervention alone, even PPP intervention, has not been effective enough that people maintain their weight. Within 5 years, people gain, but 90% of people gain their weight back. So the guidelines from the American Heart Association, Obesity Society, and OMA, the joint guidelines for obesity management is BMI 27, we're currently at BMI 30, and back up. So that's actually what the guidelines say from treatment with GLP-1 being the primary drug because of certain symptoms. So although she's mentioning the diabetes guidelines, there are guidelines for obesity management from HA and tolerance joint guidelines where the indication is GLP-1 and BMI, which is 30. In addition to that, ADA actually does have pre-diabetes guidelines, which is important in GLP-1s, in addition to lifestyle intervention. So the exercise, I'll kind of back up and say from an obesity perspective, one of the things that is awesome, comprehensive care and will-enable use of medications is not appropriate anyway. That's not what should happen. As a, from the board of directors from obesity medicine, we make a push for ensuring there is comprehensive care. Right? And that also has cost containment. Patients being on medication is not completely appropriate if you don't have nutrition therapy, exercise, and everything else. However, from an exercise standpoint, DPP's recommendation is 150 minutes a week, which has been what's been touted. There's multiple meta-analysis done on exercise, and that just shows about maybe 5-pound weight loss over a year. Somebody exercising 150 minutes. Exercise in the diabetes endocrinology and obesity world has well been discounted as a primary intervention, but it has to be part of comprehensive orthodox care for obesity management. And I think that's important because I don't think anybody, at least in the obesity world, is suggesting that patients with obesity be treated primarily with medication. It's just inappropriate to not treat them with medication in addition to comprehensive care. But there are guidelines that exist.
And I think it's also important to point out that cardiovascular benefits are seen with as little as 5 to 10% body weight loss.
Right.
Which is oftentimes achievable, difficult to maintain, as you point out.
It's impossible.
Yeah, but certainly not in the range of the 20 to 30% body weight loss that you see that some people talk about
Right.
with GLP-1. It doesn't take a lot, it takes some to make it better.
Right.
Yeah, the clinical study number is always 5%, and it's kind of that's where the data has been. Although that data is shifting now that we actually have the ability to have greater than 10% weight loss. In fact, the ACE guidelines and the AHA guidelines for gastroenterology actually tout GLP-1 agonists because of their weight loss greater than 10%. Because at that greater weight loss, the biomarkers were significantly improved. If you look at
Right.
it is
Biomarkers, but not necessarily clinical outcomes.
Well, yes,
well,
you're,
unless you want to talk about the select trial, which actually showed clinical
you're,
reduction.
No, I can understand that, but it's one of the issues I'm sure we'll hear about the select trial. But one of the biggest problems with the select trial is, they were not able to show, a dose response. That is there improved benefit with additional weight loss, or and does that benefit start as soon as the therapy starts, right? Is it independent of the weight loss? These are all questions that
right.
are very
Right.
important eventually to get the information
Right.
out to know
But
exactly
you're,
what the role of the drug is.
well, your biomarkers, like your biomarkers will have improved health outcomes.
At some point in theory,
Yeah.
But what everybody really cares about is improved clinical outcomes. You have less cardiovascular events, less strokes, less peripheral vascular disease, fewer amputations, less dialysis.
Right. Okay. You go right ahead. Thank you. Right. Right. If you look, yeah. Now, well, for the cost of all their medications, or? Are you talking about like the semaglutide? Do you know? Okay, because I don't do their cost, because at my clinic in Birmingham, these patients, their cost is based on their income. Okay, so okay. See, now my other clinic is a free clinic, okay? And Novo, the free clinic, their medications are given to them free of charge. And Novo and Lilly and other pharmaceutical companies send those to us for free of charge. And thank you. So Novo and Lily's not here, so, but for UAB's clinic, those charges are through our billing company. And those patients pay based on their income. And I don't have any, honestly speaking, I do not have any of that information as a provider. Once they leave me, they go on to the billing window. And I don't see any of that. But I could definitely get that information for you. Thank you. Thank you.
Thank you. Thank you, Cliff. So as the slide says, my name is Jeff Goforth. I'm a pharmacist and a medical account associate director for the Mid-South. And I cover Alabama, Georgia, South Carolina, Tennessee, and Mississippi. My role is to provide scientific information. So when we do talk about cost and things like that, that's not necessarily my role, but I can share some insights. But thank you, Dr. Hess. I mean, I felt like I was back in school for a lot of that. And speaking of school, I'm a injured Georgia Bulldog here in enemy territory. So y'all take it easy on me today. So disclaimers, I don't have a disclaimer slide, but obviously I work for Novo Nordisk, the manufacturer of a few of the diabetes and obesity medications that we're talking about. There are other manufacturers as well, but obviously I'm exposed to our data more than anything else. So welcome questions and comments and conversation. I love to hear both sides of the story. But, you know, I'm here today mostly to share just insights around some of the topics that we've already talked about, and also just an update around the SELECT trial that we mentioned, which is the cardiovascular outcome trial for semaglutide, the obesity version of semaglutide known as Wegovy. So just a couple reminders, and I know we talked about this. You heard a lot of clinical data the first time around. You heard a lot of opinions and statistics and things like that, but just a few things to keep in mind. Over 90% of people with type 2 diabetes have overweight or obesity. So it's kind of hard to separate these two things. And the rate of obesity is growing at an unsustainable rate. By 2030, it's expected to be over 50%. Now, if the role of the task force is to give recommendations on to reduce the prevalence of diabetes and obesity and prevent the downstream complications, we have to look at prevention, right? And medications are not the only answer. I mean, I work for the pharmaceutical company, but as Dr. Parker mentioned, comprehensive care is what we advocate for. It's going to take every tool available in the toolbox to have an impact on these epidemics. Behavioral, nutritional strategies, lifestyle coaching around diet and exercise, surgical options as well as medications, and counseling around those medications. As you can see on the slide, that obesity is a chronic disease. I don't think anybody's arguing that it's not a disease, but it's not necessarily treated that way. It's an expensive problem, and minorities bear a disproportionate burden of the disease. So we talk about medications a lot, again, but that's not all we're here to talk about. At the last meeting, there were several points raised around the clinical experience and the benefits of the medication, but there were also several points that shared that seemed to support not making these drugs available to patients in some situations. And I'll just address some of the concerns that were raised, just to make sure, just to add context. We don't have all the answers. That's what we're here for, right? But one of the questions was, what happens when you stop the medication? The weight comes back, and the data supports that. Like when you look at a population, look at the trials, when you stop the medication, it comes back. But you can argue that this actually supports obesity being a chronic disease. That's what happens in any chronic disease. If you stop a blood pressure medication, the blood pressure goes up. You stop cholesterol goes up. It's a chronic disease, and it's not for lack of willpower that these the symptoms return if you stop the treatment. That being said, there are situations where people may not need a lifetime of therapy, where you may be able to stop the medication and the weight not come back. A situation where maybe a patient's overweight, they can't exercise because they have knee pain, and you lose 30 pounds, you lose 50 pounds, you lose whatever. Now you can exercise again. You can go do yard work. You can go to the gym. You can walk. That patient might be able to switch interventions. If the intervention of the medication stops and you start the intervention of lifestyle, you might be able to maintain it for that patient. So I just say that to say this should really be individualized. Like when we look at this, the control should be given to the patient and the provider to make the best choice in that situation. Low adherence rates were also mentioned, and I'd say that this is no different than any other chronic disease, hypertension, diabetes. We struggle all the time to try to figure out better ways to make medications so that patients can tolerate them better. And the factors are many, like the reasons behind the low adherence rates, not unique to obesity, not unique to diabetes. It can be cost, it can be high deductible plans, it can be change in insurance coverage, and then you've got the clinical things. It can be side effects, it can be tolerability, it can be the availability of the drug. We had supply chain issues lately. So there's a lot of reasons when we look at adherence numbers that factor into that. So I think one thing that would support is the importance of comprehensive care. Having a wrap around these patients who are suffering with these diseases to make sure they have the counseling and the support that they need long-term to stay on these medications. And understand that, if it is the side effects, if that's the problem, there are ways you can coach your patient through that. They're mostly GI side effects, if we're talking about GLP-1s. There are specific things that patients can do to make them better tolerated and potentially increase adherence rates. I know the slides aren't showing what I'm talking about. I don't really have slides about these things. I'm just kind of trying to, add some context. But the off-label use was also mentioned, and this is a problem. There are some people who seek these medications that don't necessarily qualify, based on the FDA indications. And it is less likely in a situation where patients have coverage for the obesity medication that they seek the diabetes medication for off-label use. So that's another situation where we need to make sure that, the prior authorization process can address these issues. You can have this up front, say you have to stick to the FDA label. This is how you get the medication through the prior authorization process. So that would help to limit the number of people who are seeking these medications who don't qualify. I think claims data supports that this is the exception rather than the rule. We have data that shows, the average BMI of a patient who takes anti-obesity medication, specifically semaglutide, is 38. So this would be a patient who is 5 feet 5 inches tall and weighs 228 pounds, or someone who's 5'11" and weighs 272 pounds. That would be a BMI of 38. I don't think anybody's going to argue that that patient, on average, is well within the qualifications of these medications and meets the FDA-approved label. The other thing to mention about off-label use is, the guardrails are really important. Again, the comprehensive care. You can require that a patient be a part of a lifestyle management, a weight management program, to maintain these medications. So that would serve a couple purposes. It would eliminate the people who maybe weren't serious about the weight loss, and it would also provide that long-term counseling for those patients. But it's no reason to really prevent access for patients who truly need it. Cost. So this one is complicated, and direct costs are negotiated. And I'm not really a part of that process. I'm the science person. But I can share a few insights from the published literature to try to add some context. So there's no doubt that drugs that are still in patent are expensive, including the anti-obesity medications. And you can make the argument that it's important to bring back money in to fund innovation and research. I mean, to bring a drug to market costs billions of dollars. Clinical trials cost billions of dollars. So that's part of the reason why newer medications are expensive. But the list price of $1,350, I think, was mentioned several times. But in reality, it's very rare that someone actually pay that for the medication. Less than 1% of people actually pay that for the medication. As a payer or an employer, it's important that you understand the net cost of these drugs compared to the list costs. And there's a recent publication that estimated that the list price, or the gross price of the drug, compared to the net cost, is about 50%. Now, talk to your PBMs, all the contracts I don't have access to. I don't know that you all do either, but it's a conversation to have with the PBM about what the actual net cost of a medication is. It's not the list price that we see of $1,350. Very rare that anyone actually pays that for the drug. And that's just a symptom of the way our system is set up in the U.S., our pharmaceutical system and access to medications. It's also important to keep in mind as you look at modeling for PBM and utilization that you pay special attention to utilization rates, because oftentimes in the calculations there'll be like a very high utilization rate, that meaning that people who qualify for the medication actually take the medication. In general, real life experience, it's generally pretty low, like usually below 5%. There's several publications, they're kind of dated at this point, but around 2 to 3%. Yes, yep. Question was, is $1,350 cost per month? And yes, that's the list price per month supply. So another point to make around cost is if we're looking to make the most vulnerable among us improve access to quality care, Medicare gets the absolute best price on top of the regular rebates that the pharmaceutical manufacturers pay. There are supplemental rebates and other incentives, I guess, to provide medications at a very low cost to Medicaid recipients. Your neighbors to the west in Mississippi just added anti-obesity medications to the formulary in July. And your neighbors to the north and the east have coverage for adolescents currently and are evaluating coverage for adults as we speak. Questions were raised about the coupon cards. And when drugs are new to the market and they don't generally have insurance coverage, right? Generally takes at least 6 months before there's any insurance coverage. So in order to have experience with the drug, manufacturers offer coupon cards. So helps offset the cost of the actual medication for the patient. They function kind of like samples in that, it's a low risk idea for the provider and the patient to try out the medication for a patient to see if they can tolerate it, see if side effects are tolerable and if it's effective. So I think coupon cards do serve a purpose and are useful, but just wanted to mention that came up in the last task force as well. Another point to mention is that cost may change very soon. We're in an interesting time for anti-obesity medications. 3 or 4 weeks ago, there was a new anti-obesity medication approved, tirzepatide. So we expect it to be on the market before the end of the year. Increased competition generally lowers costs, so it'll be interesting to see what happens there. The other thing is next year, one of the GLP-1s, liraglutide, we're expected to be biosimilar. So this is like a generic. So we're expecting more competition, potentially lower cost very soon, and it's a dynamic market. Things are changing pretty quickly. And as we're talking about cost, I think another thing to keep in mind is that, payers tend to look, and PBMs tend to look at pharmacy cost only, like the cost of the medication. But it's important to keep in mind that a lot of things that Dr. Hess talked about and the providers at the last meeting talked about, the cost offsets. There are over 200 comorbidities with obesity, and half of people with obesity have 5 or more of these comorbidities. So by taking the medication, did you prevent a hospitalization? Did you prevent a heart attack? Did you prevent a long-term care? Those are questions that we need to answer. And it's very difficult because it's complex. And if you're lowering weight, you're likely to impact several, of these downstream consequences. It's hard to put a dollar value to it. Questions were raised about the long-term consequences of these medications, specifically GLP-1. So, and this is getting more into the science, I feel more comfortable here, but GLP-1s is not a new molecule. It was discovered in the human body over 60 years ago. It's an incretin hormone, and it does a lot of different things in diabetes. But for obesity, one of the major way it works is it's a satiety hormone. It tells your brain basically that you're full. So it's been studied in humans for diabetes well over 20 years. The first GLP-1 for anti-obesity medications was approved almost 10 years ago. The newer version, the semaglutide version has been on the market for 2.5 years. We've got more on the way. There's a lot in the pipeline. So this is not a new molecule. Like when we talk about safety, you actually think we're in pretty good shape. I mean, the question was asked, what happens to these patients take the drug for 50 years? I can think of maybe aspirin and insulin. I think that's probably all we have 50 years of data for. So it's extremely rare to have very long-term data for any medication for any chronic disease. But it's an example of treating obesity differently as a chronic disease than some other things to have different expectations. But what we do know is what happens if we don't treat obesity over 50 years or even over short term. Like we know the complications, those 200 that I mentioned, and I'm finally getting to this slide here. 200 plus comorbidities for obesity, half of people having 5 or more. You got the cardiometabolic issues, the heart attacks, strokes, fatty liver, and heart failure. Mechanical issues like knee osteoarthritis, back pain, and injuries related to those mechanical issues. Something that's overlooked a lot of times is the anxiety and depression that comes along with obesity. Alzheimer's risk doubles in obesity. Infection risk increases. We saw that with COVID-19, right? Over a dozen obesity-related cancers, as well as many others that are not on this slide. As Dr. Hess mentioned, obesity increases your chance of type 2 diabetes. The CDC says 7 times. Dr. Garvey said 6 times. I'd go with Dr. Garvey probably. So it increases your risk of type 2 diabetes. And if you have uncontrolled diabetes, then you can add things to the list like amputations and blindness and dialysis. So these are the extremely important consequences of not making any changes, of not treating as prevention, not using prevention. So the bottom line for I think we've been complaining about obesity since the 80s. That's where we started to see a big spike in 30 plus years at least, and we finally have some safe and effective medications to treat it, some highly effective medications, and let's just make sure that they're part of the solution for patients and providers, along with strong reimbursement for lifestyle coaching and support, as well as the surgical options. So this graph shows us that there are certain thresholds that where we can expect certain outcomes. And just for context, we talked about it already, but lifestyle intervention, you can expect about a 3% body weight reduction on average. And then you got bariatric surgery where you're talking about 20% plus, body weight reduction. And, now we have medications that are filling the gap between that 3% and 20%. And this is, you meet some very important thresholds in that gap. So the 3%, as we mentioned, and Dr. Embry, you mentioned at 5%, you see some pretty good results. You see reductions in blood pressure and improvements in blood sugar at that result. But when we start moving our way up to 10%, 15%, we start to see more impactful outcomes. Outcomes is what we want, right? We can see remission of type 2 diabetes. We can see reductions in cardiovascular mortality, improvements in heart failure, improvements in fatty liver, knee osteoarthritis. There's a lot of improvements that we can see at higher thresholds. So, you know, the newer generation of the anti-obesity medications are now meeting these certain thresholds that could potentially be beneficial in these complications. And now we have the trial that actually shows that to be true. And I want to be clear, this is the SELECT trial, and I was requested to share this data. This was only published 3 weeks ago. Wegovy, the GLP-1 semaglutide for obesity, is not indicated to prevent cardiovascular disease. Okay, so this is just for your information, not that we are advocating using it in these situations yet. So this data actually builds on the legacy of GLP-1s in cardiovascular disease. If you go back and you look at the, from 2016, there were a couple trials published for the diabetes versions of GLP-1s where they showed reductions in cardiovascular death and non-fatal myocardial infarction, heart attack, and stroke. And you know, we didn't really expect that. It was kind of a surprise. So it was really nice to see it, and that's part of the reason why they've really moved up so far in the guidelines, because we're not just talking about lowering glucose, which we've been talking about for years. We finally have medications along with the SGLT2s that can actually reduce cardiovascular events. As I mentioned, presented 3 weeks ago at the American Heart Association, simultaneously published in the New England Journal of Medicine, one of the most rigorous and well-respected journals out there, the peer-reviewed journals. And it evaluated several points. It evaluated a combination endpoint of cardiovascular death, non-fatal stroke, and non-fatal heart attack. These patients all had overweight or obesity, and they had established cardiovascular disease, meaning they already had a heart attack, they've already had a stroke, or they have peripheral artery disease. So we've never had a medication show benefit in this population until now. And you know, this is a 5-year study, 17 and a half. Oh yeah.
Because that's completely untrue.
What's that?
That you've never had a drug show this effect. I mean, you got antihypertensives.
Oh, I'm sorry. Anti-obesity medications. Sorry. Yeah. Yes. Yes. Yeah. Yeah. No. Yep. Oh yes. Yeah. No, you're correct. Yeah. I'm sorry. We've never seen a drug in this class show this kind of, or anti-obesity medication. Nothing medication that reduces weight show these kind of results. No, you're absolutely right. Like, I mean, we can prevent, you know, cardiovascular disease with statins and ACE inhibitors and aspirin. There's a lot of ways to do this, yes. I misspoke. So this is the primary endpoint. So this, again, was a 5-year study, 17,500 patients. And some of the study sites were right here in Alabama. Again, type 2 diabetes patients were excluded from this trial. This is what makes it unique. You know, this is what we never seen before in anti-obesity medications with established cardiovascular disease. Average age was 62, average BMI was 33. About 2/3 had prediabetes at baseline. About 2% of the US population would have qualified for this trial, about 6 million patients. But what it showed is if you look at these two curves, I mean, it's a 20% relative risk reduction in that 3-point endpoint, the cardiovascular death, non-fatal heart attack, non-fatal stroke. Something that is unique is the early separation of the curves. Like we don't have statistics at the 6-month point, but you can see that the curves are separating early. That's being investigated. We're not really sure if that means anything because, as Dr. Embry mentioned, you know, the weight loss in this trial was not what we typically see for an anti-obesity medication. It was 9.4%, I believe. You know, where a lot of times in the anti-obesity trials for semaglutide, we see 15% on average. The difference is this was a cardiovascular outcome trial, not a weight management trial. So the setup of the trial was different in a different patient population as well. We also found that patients who did have prediabetes at baseline, by the end of the trial, they were 9 to 10 times less likely to have prediabetes at the end if they were on the semaglutide treatment arm. As far as safety goes, adverse events did lead to more discontinuations with semaglutide compared to the placebo arm. It was about 16 to 17% compared to about 8%. Gastrointestinal events were the main reason for that. Although serious adverse events were very similar between the arms. We didn't find any new adverse events that had not been reported before. So why is this study so important? Why is this select study important? So we've never seen this kind of data before with anti-obesity medications. So we have to decide what is the value of this, right? We have to decide what is the value of reductions in cardiovascular death. I think one thing that is important is for those who might argue this is cosmetic or not worth treating. I don't think we can make that argument anymore. These medications can save lives in patients who are overweight or have obesity and established cardiovascular disease. And these medications should be a therapeutic option for those folks. So what can the task force do? Evaluate the current situation for Alabama in the care of diabetes and obesity. What care is available and what is covered and who has access to it. Behavioral and dietary counseling. Are clinicians reimbursed for the lifestyle, behavioral and nutritional counseling that at a high enough level? Is it worth their time? I think that's a big part of it, especially when we look at adherence and staying on these medications. Like what does that look like? Who has access to bariatric surgery and who has access to some of the most safest and most effective medications we've seen for anti-obesity treatment? And if they don't have access to these things, why? What are the barriers and how can we address those barriers? So again, focus on prevention, make all the tools readily available to clinicians and patients to battle epidemics of diabetes and obesity, to prevent those 200 plus comorbidities, hopefully. The residents of Alabama are at a disproportionate risk for these diseases, and they could use your help and support. So I'll take questions now.
One quick question related to long-term issues. For obesity, the dosages are generally higher than those for type 2 diabetes, correct?
Yes, sir.
So the point being is the higher dose for a long period of time, we don't have a huge number of people
That's true.
to look at as compared to the type 2s.
That's true. Yes. Yeah, the maximum dose for the diabetes, if we're talking about semaglutide, the maximum dose for diabetes is 2 milligrams, and the maximum dose right now for the Wegovy version is 2.4 milligrams. Yep.
Significantly higher, potentially for a longer period of time.
Right.
How does the 20% reduction in cardiovascular risk, which makes all kinds of cardiovascular events, compare to other standard treatments, such as antihypertensives?
Yeah, I'll have to get that to you because I mean the patient population is different. I mean, if you're talking about established cardiovascular disease, it's I don't. Do you know? Is this a leading question?
Yeah.
Okay, go ahead.
And the point is for controlling hypertension, the relative risk reduction is 60%. For statins, it's 40%. Now we have a very relatively expensive medication comes in with 20%. So just keep that in context, which is it is effective. No question about it. There's risk reduction, but it's not even.
So you can also.
Are more routine therapy.
Well, you can also argue that this was in addition to those medications. If you were going to measure this without ACE,
The event rate is so low that 20% of a small number is a pretty small number. So
What's the number you
it wasn't calculated in this publication. My guess is because when you go back to these comorbidities and half of people having 5 or more with obesity, it's not just about the primary endpoint. So I think that you can do back of the envelope calculations, but it was, I think, specifically not, the New England Journal decided not to put it in because it's much bigger than just how many heart attacks and strokes did you prevent.
And I think it's one of the issues that we're still trying to figure out.
Right.
We need more data from this study or additional study to really figure out the role.
Yeah.
The point just being is that 20% risk reduction is not miraculous. We've never seen anything like this from any other medication reduction.
Not from other medications, but do you know what would happen if we used this and did not use it on top of those other medications? Another answer, we can't answer that. But I can guarantee you it'd be higher than what it is, don't you think?
I don't know.
Yeah.
But as you remember, as you start multiplying risk reductions, that 40% reduction on top of a 60% reduction on top of a 20% reduction starts to become very small.
Right. Yeah. Residual risk. I mean, you're going to have to make some choices, between, cost of medications and how much risk is reduced. But yeah, I don't think it's fair necessarily to compare it to those medications because these medications were not around when those studies were done.
No, but I do think the point that I tried to make the last meeting is, per dollar of risk reduction, this isn't necessarily a good value. It's nearly as good a value as the more routine, older things.
So I guess it depends on how you calculate the cost of the medication too. Like if you're using 1,350, then maybe not. If you're using 100% utilization, maybe not.
Back and go, the larger problem is how we price medications.
Right. Oh, yeah, absolutely. I agree. Yeah.
Why is it this way? It's because people make more money that way.
Yeah.
There's margin in mystery. He's a good friend of mine.
Yeah.
And the other point, I think, is that you brought up that it is an evolving landscape. Just the news release today was talking about how additional anti-diabetes medications are coming on the market. Some drug companies are buying up smaller ones that have these products. You made a very, very good point, which is the landscape is changing.
Yeah.
And it's a very good chance that without any intervention whatsoever, I would assume that the price issue will take care of itself.
Yeah, I wish I knew. Yeah, I'm not involved in that process, but yeah, things are changing quickly and a lot more entries into the market coming, a lot in the pipeline, all around these disease states. But back to the cost, I would highly suggest you talk to your PBMs about the actual cost of the drug. And when we're doing calculations, well, it's margin of mystery, right? As it gets buried somewhere. But the fact is, they're heavily rebated drugs, and where does that money go? I don't know.
I do think, if there's an issue that we could try and deal with is making sure that everybody knows what the true end cost of
Right.
any medication.
Absolutely.
Not just, government
Yeah.
what that true cost is, because we don't know. And it's very hard for people running health plans to know, this medication is $10 a pill and this one's $3 a pill. It's impossible. Very difficult.
Yeah.
Yes, you actually stated that it was in this population, right? So like recently, multiple medical societies actually called on the FDA because traditionally, the way that these patients have been excluded from trials. So it's actually a big problem. And so because of that, because of the reduction in stayed in a particular population, in some cases excluded in trials, that there actually is this is a very important trial for patients who are overweight because it was actually in that patient population that was actually being studied. Previously, that has traditionally not been done, particularly for cardiovascular studies. So,
I have to go back and check. I'm not aware of that. I know
I can send you the link of the medical societies actually.
Well, I'm actually interested in the data. So many of what medical societies say is just biased. So
So
that's my
it's
job.
not, so
I go back and look at
it's
the
not
source
biased
data.
against patients with obesity and overweight when we're discounting that they're a particular patient population, particularly when it comes to complications in those patients and drug monitoring in those patients and what happens in those patients. That the bias is excluding the patient population and acting like that. That's what the bias is.
Any more questions specifically for Dr.
If you guys need anything from me, resources, references, be glad to share them. And also, I'd love it if you flip-flopped your, if you had a really good diabetes care and worse football team, that would really help me out. Really appreciate that. All right. Well, thanks, guys.
Well, I think Senator Weaver and I will work on that. I would like to try during the legislative session to have at least 2 meetings while we've got everybody here, just because it
Is that